Hello, I'm Choi Sung-hwan of the Department of Orthodontics. I will present about antifouling and bioactive glass ionomer cement. Biofilm, a morbid germ in the oral cavity, consists mainly of more than 700 microorganisms, with a variety of microorganisms. And the most important thing is the extracellular polymer substance, which eventually constitutes biofilm's multifunctional scaffold, which makes it difficult for dentists to try to prevent tooth decay. Intraoral biofilm occurs in subgingival biofilm, surgingival biofilm, endodontic biofilm, peri-implant biofilm. Tooth decay is mild or hemorrhoids, and it can also be caused by peri-implantitis around implants that are mainly planted in prostheses. On the right, I'm showing you a device called circular retainer, a retainer used in the correction department. And you can see white plaque piled up around the retainer. No matter how hard patients try to clean their oral hygiene, it is not easily accessible physiologically because there are the following problems. First, initial advice is needed to enter the nature of biofilm. Initial attachment is the attachment of several medical devices used on the tooth surface of microorganisms or in the oral cavity. After you start attaching it, it's not just bacteria, but bacteria form EPS. We're talking about early biofilm formation, and when EPS is formed, EPS themselves create a three-dimensional 3D structure, which creates a space for themselves to live in, and so much so that when they overflow, they end up falling apart and moving elsewhere, so that they can observe biofilm's life cycle well. If we look at what methods can be used to remove these biofilms, the simplest way is physical removal. As you all know, cleaning the device with a toothbrush or brushing your teeth, or physically remove biofilm around your teeth using sprays or jets such as Waterpick. But when I look at these things, because I look at the corrections, the things that require the cooperation of patients are not going well. Like children and adults, they don't have exactly the right brushing, and another is that the way they remove biofilm can sometimes cause surface abrasion. You can also find that countless devices used by grandfathers in dentures and calibration departments are brushed by strong bristles, resulting in surface abrasion and surface damage, which increases the adhesion of biofilm. The way we approach it in a more physical, but slightly different way, such as ultrasound or non-thermal plasma, which we've studied a lot, is very limited in terms of the size of the tip, because it's very small. And after removing it, there was another problem that biofilm was generated. One of the methods used to remove biofilm in many departments that currently perform periodontology and surgery is to topically apply a chemical agent called minocyclic. These methods can actually cause a definite biofilm removal in a topical area, and the problem is that the EPS is very thick and has a complex structure, so the penetration does not work well and tends not to heal more than you might think. Finally, there's something called chlorexidine or hexamidine that we can use in a supermarket or pharmacy, or the most famous Listerine broad-spectrum antimicrobial drugs, which are actually struggling to get rid of biofilm in dentistry because they don't have the ability to drop solubility or pass EPS. As a result, this EPS is, as a result, a house of germs that biofilm forms. Because it has a multilayer scaffold, there are countless microorganisms in it that are contacted and communicated with each other because they create their own small space, microenvironment. The pH that is much more acidic than the pH commonly found in the oral cavity remains low. And in this low pH state, bacteria and proteins are fused and scaffold is made, so it is very difficult for antibiotics to penetrate and weaken, even if numerous antibiotics are developed. After all, because these dead and living cell microorganisms are mixed together, the downside of the structure of the heterogeneity biofilm, that is, the deeper you go in, the more acidified the part. Therefore, the more antibiotics are difficult to penetrate, and it is not easy to specifically kill the microorganisms. The reason I explained this is that from the beginning, we found it very difficult to approach in situations where biofilm was attached, and what we've studied so far is quantitative ions called capital ions. With these quantitative ions, we thought about removing biofilm using antifouling effects, which we say are defensive effects. So what about quantitative ions? Quantitative ions are unusual substances that have positive charges and negative charges at the same time, and electrically they are neutral. This substance is not only used by us, but is known to be used for medical contact lenses, contact lens eye drops. This substance is highly solubility. There are three famous materials among the polymerized substances. 2-methacryloyl oxymethyl. Phosphorylcholine, MPC, is the most used, and there is SBMA, a sulfobutane methacrylate called CBMA, carboxyphene methacrylate, which has been used a lot in recent years. These substances have plus charge and minus charge and are electrically neutral by combining the two. But when they become a combination of certain dental materials, they form a very thick film on the surface of the dental material and on the surface of the medical device. When these meninges are formed, the membrane itself can prevent microorganisms from approaching, which is eventually caused by a polar material with plus-minus charge. So it has a thicker and stronger meninge than a material that only has a positive charge on one side, such as the polyethylene glycol, which is commonly used in conventional medical devices. These thick films eventually have a three-dimensional defense effect called a steric hindrance effect, so they have the shape that makes it easy for foulant to bounce off the surface, so that they don't touch the surface easily. Next, it was found that these substances form a meninges as a result, eventually forming a meninge layer on the surface of the tooth or medical device, so that bacteria can inhibit the adhesion of proteins that are essential for protein adhesion. When NPC substances were added to a specific percentage of what we had previously studied, most dental restoration agents were able to suppress the attachment of these non-specific proteins, which could inhibit the formation of biofilm. Therefore, our approach is to achieve surface modifiers of medical devices or dental materials as a whole step of initial adhesion. We began to approach this approach by creating a smart surface from a surface modifier, thinking that preventing bacteria or bacterial biofilm from attached from the beginning was much more efficient than removing biofilm, which was already attached and complicated by DPS. That's why I was introducing this technology into countless dental materials, and I remember having a lot of patents, and 2 years ago, I announced it here. But the reason I'm here is that the biggest effect of the reasons we're discovering is surprisingly found in glass ionomer cement materials. Glass ionomer cement is described behind the scenes, and glass ionomer cement is the most common cement used in raise strengthening, remineralization, dentistry. So what is bioactive material? When cavities are virtually developed in dentistry, dentin or dentin can be destroyed in cavities or acids. For what has already been destroyed, bacterial biofilm is removed and dental fillings are added, which means that when the material is restored, hydroxyl apatite mineral, a component of CAP called apatite, naturally forms. In dentistry, hard tissues that were once destroyed do not regenerate, and when these materials are used, we aim to have a new apatite formation. If so, bioactive material, known on the market, has the characteristics to deliver countless microorganisms. These ions need to bind to collagen, mainly because they must form apatite crystallization. And when these ions are released, not only the mineral formation occurs, but also the low acidity pH can be seen to be raised and more neutralized. And the mineral depot part that appears to be sky blue color in the B figure is characteristic of the ray-energizing material we are targeting. Ion release material found on the market were substances such as glass ionomer cement, resin-modified glass ionomer cement, mineral nitride oxide, and ZPCs, and found that the ion-releasing effect could be increased when combined with zwitterion in glass ionomer cement, which is currently the most commonly used in dentistry. So what ingredients does glass ionomer cement consist of? This is the most commonly used cement in dentistry and consists of fluoroalumino, silicate glass. As a result, the fluoro in front of you is fluorine, which dentally says is good because it affects the fulfillment of fluoroapatite. Therefore, GIC is made of an acid-base reaction in which perfluoroalumino, silicate, glass, and polyacrylic acid combine. Glass ionomer cement powders have substances such as silicate, SiO2, Al2O3, and CaF2, and consequently a powder consisting of glass, which is attacked with acid to form salts through bonding and chemical reactions with acid bases, which eventually lead to glass ionomer cement. Then, as you can see when the MPC and SP are mixed, as shown when quantitative ions, zwitterins are added for anti-fouling effects in glass ionomer cement, biofilm is found to be poorly attached because the defenses are eventually higher than control. A and B experimented with S mutans, C and D experimented with human biofilm, and were able to significantly suppress the adhesion of biofilm and S mutans. However, as a result, the glass ionomer cement consists of the glass silicate that we mentioned earlier. The more NPOs called non-bridging oxygen, the more cracks in the silicate, and the cracks in the silicate, the more silicate cracks that form the glass ionomer cement, leaving room for ion emissions to increase. So industrially, we were trying to increase the NBO by referring to these ions as network modifiers, such as LiNaAJ, but strangely, when our zwitterion acted as a network modifier and mixed two substances, MPC and SP, we were able to see that these ion emissions eventually increased the rate at which the pH was raised quickly. Next, we formed the biggest characteristic of bioactive materials, an apatite called amorphous calcium phosphate, which is actually the key to patent control, which is just GIC. Conventional GIC obviously needs to form calcium hydroxyapatite in a solution called analog SBF, which was not formed at all when we experimented. However, strangely, using zwitterion alone, such as MPC or SP or MPC plus SP alone, or using zwitterion in half as duplicates, led to a much larger apatite formation. Why did this happen? When we've done our research, it's not public until now, and we'll be publishing it as a paper next month after the cleanup ends. In the end, this zwitterion acts as a zwitterionic network modifier. If you use the MPC alone, you can't roll the zwitterionic network modifier because the net charge is 0. And when MPC and SBMA use it as a mix rather than alone, net charge is not 0. What happens if net charge is not 0? As a result, the hydrogen bonding water film layer increases more and has a hydrophilic property. However, this increase in hydrophilic bonding that attracts water will result in an increase in NBO. Figure A on the left refers to a blue mountain, and it is found that the ratio of non-binding oxygen is much higher in MPC plus SB. Likewise, in Figure B, it can be seen that the non-binding oxygen called uncharged amine increases more. When MPC and SP are used alone, if the net charge is not 0, the ion release increases as the role of the zwitterionic network modifier is proved, and the silicate retinal structure that forms this glass cracks, and the channel release opens as this crack occurs. As a result, the ion release channel creates a structure in which water can easily pass, thereby increasing the ion release. Ions are released at a high rate until ion equilibrium occurs when glass ionomer is added to one solvent. After that, it is seen that it diffuses slowly with long term. As shown in the previous figure, it is said to be a glass ionomer, that is, a bioactive substance that can release ions, but does not achieve mineralization in the similar object, SBF, solution. However, when this material is added, it increases the NBO and increases the ion release channel. As a result, it can promote reinforcement at a high speed, so when the material is filled in the tooth with cavities, it is rapidly ion releasing, and as a result, it is thought to be a technology that can promote minimalization while acidifying pH. And so far, it has suggested that bio-friendly and bioactive materials can be developed when applied to ion release materials beyond the properties of quantitative ions. Finally, when these zwitterionic network modifiers are combined with GIC, the defense effect, as a result, does not have bacteria, but also the structure of bacteria and microorganisms is normalized according to the increased amount of ion emissions. And many different bacteria and microorganisms live in conventional salivary, and when used alone with MPC and SB, a much greater variety of microbial species are occurring when used together. Regular GIC such as control shows a much more normal Streptococcus calivaris increase when MPC and SB are jointly used, while harmful bacteria such as Streptococcus periodonticum are mainly achieved, and the Streptococcus salivarius benefits are increased when MPC and SB are used at the same time on the last slide. In other words, there are much more microbial funguses that salivar has, but when using MPC and SB as a mixture compared to the increase in harmful bacteria when used morbidly, control, or alone, we have concluded that the beneficial bacteria increase, and what we think will not contribute to normalizing the oral bacterial layer by combining these things rather than just the defensive effect or bioactive. Thank you for listening.